Welcome to the RSNA Radiographic Podcast. My name is Agustin Marrero, an Argentinian radiologist specialized in musculoskeletal trauma and sport imaging. I am co-founder of MSK La Plata Imaging, head of the Diagnostic Imaging Department at Club Estudiantes de La Plata, and head of the Musculoskeletal Radiology Department at CITEC. I am truly honored to have been invited to discuss our work entitled MRI and ultrasound in hamstring sport injury assessment, anatomy, imaging findings, and mechanisms of injury. Our authors include Augusto Napoli, Leandro Massa, Ricardo Trueba, Nicolás Cédola, Tomás Pascual, Cecilia Vélez, Micaela Rabino, Ricardo Coveñas, Pablo Eiber, and José Tapia. This article reviews the clinical characteristics, mechanisms, and location of hamstring injuries based on MRI and ultrasound findings, highlighting key factors that help guide treatment strategies and prevent recurrent injuries. As we know, muscle injuries are the most frequent type of sport trauma, and among them, the hamstrings are the most commonly affected muscle group, particularly the biceps femoris. The hamstring muscles originate from the ischial tuberosity and insert distally. The biceps femoris insert into the head of the fibula, while the semitendinosus and the semimembranosus insert on the medial aspect of the tibia. As for understanding of the anatomy, insertions, and myoconnective junction of each muscle is essential because these junctions are the typical size of injury, so the precise location of the injury and the specific anatomic tissue involved are the most important prognostic factors. Clinical characteristics also help to understand the mechanisms of injury. For example, injuries occurring during sprinting are commonly associated with the long head of the biceps femoris, whereas injuries caused by overstretching are typically associated with the semimembranosus. The time elapsed since injury is critical when interpreting imaging findings. In the acute phase, at first 24 hours of the muscle injury, typical findings include feeder edema, fiber gap, hemorrhage at the dissolution site, and loss of tension, particularly in case of tendon involvement with retraction and wave time. The acute phase is followed by an inflammatory response, typically occurring on the second day. By the seventh day, imaging findings reflect the healing process and the scar tissue formation. The scar tissue formation begins as a soft callus, which manifests as a tissue hyperintense center surrounded by a thin and hypointense peripheral line, and finally, the formation of a hard callus with low signal intensity on T1 and T2 waves image. Pain is another key clinical factor that we need to take into account before starting our study. For example, hamstring injuries that force athletes to stop playing or cause pain while walking for more than one day are usually associated with more severe injuries and longer recovery time. One important thing to know is that injury sites tend to be consistent within each muscle and are usually associated with the same sporting movement. Understanding this will help us to better locate and interpret the muscle injury. Ultrasound and MRI are the imaging modalities of choice for evaluating muscle and tendon injuries. Both offer high resolution and are effective in identifying the injured muscle, the extent of injury, and the involvement of the connective tissue. These modalities are complementary and should be optimally utilized by the radiologist. Ultrasound using a high-frequency linear transducer is excellent for evaluating superficial muscle injuries and non-insertional lesions. It provides excellent anatomic detail of muscle fibers and myoconnective junction, high sensitivity for scar tissue and calcifications, and allows direct correlation with clinical findings through palpation, dynamic maneuvers, and cooperation with the contralateral side, particularly useful in low-grade muscle injuries. MRI using standard protocols with T1 wave and fluid sensitive sequence in at least triplanes is superior for evaluating deep muscle injuries, such as proximal hamstring injuries, and for defining tendon involvement. There are several muscle injury classification systems, such as Munich Consensus, the British Athletic Muscle Injury Classification. While all are useful, muscle injuries are highly variable and do not always fit neatly into a single classification. Therefore, determining the location and the extent of the myoconnective tissue involvement is essential to guide treatment and predict return to play timelines. Let us now focus on the biceps femoris, which has two components, the long head and the short head. The long head shares a common origin with the semitendinosus at the ischial tuberosity via conjoint free tendon. This conjoint tendon extends into the muscle bellies of the long head of the biceps femoris and the semitendinosus, forming the proximal and central myotendinous junction around the intramuscular tendon. This region is particularly important as the vast majority of injuries occur here. In the middle distal portion of the thigh, opposing epimysial condensation from the long and the short head forms the distal myotendinous junction, which appears as a T-shaped structure. Distally, the tendon inserts on the lateral aspect of the fibular head. The long head of the biceps femoris is the most commonly affected hamstring muscle, and injuries may occur along its entire length. These include injuries at the proximal insertion on the ischial tuberosity involving the free tendon. These injuries have the worst prognosis and may require surgery. Another common site of injury could be at the proximal myotendinous junction, injuries along the intramuscular proximal tendon extending to the mid-distal third of the thigh. Here, it is really important to differentiate whether there is involvement of the anchoring muscle fibers or if there is also involvement of the intramuscular tendon. Injuries involving the intramuscular tendon and adjacent muscle fibers generally require a short return to play time and thus affecting the proximal free tendon. However, return to play time is significantly longer when intramuscular myotendinous junction injuries include disruption of the intramuscular tendon compared with injuries limited to muscle fibers alone, and these cases carry substantial risk of re-injury. Another common site is at the distal myotendinous junction at the T-shaped structure. This type of injury can sometimes affect not only the long head of the biceps femoris, but can also extend to and affect the short head, prolonging the recovery time. Finally, injuries at the distal tendon insertion are often uncommon. The semimembranosus muscle is the most medial of the three hamstring muscles. It originates separately from the long head of the biceps femoris and the semitendinous muscles at the ischial tuberosity. The semimembranosus has a large proximal free tendon and a proximal aponeurosis, with the muscle belly originating more distally and increased in size toward the distal and medial aspect of the thigh. Assessment of the proximal tendon integrity is crucial, including evaluation for transverse or longitudinal splits. In this type of injury, MRI is better than ultrasound because it allows for a better characterization of the injury. The proximal tendon extends into the middle third of the muscle belly as an intramuscular tendon. Muscle fibers arise around this tendon, and injuries most commonly occur along this central myotendinous junction, and generally, the typical mechanisms of injury is during a stretch with hip flexion and knee extension. It is essential to differentiate injuries that involve only the anchoring muscle fibers from those that also affect the intramuscular tendon. Distal semimembranosus muscle tears are considerably less common, and finally, the semitendinosus muscle shares a common proximal origin with the long head of the biceps femoris at the posterior medial aspect of the ischial tuberosity. It has a long muscle belly divided into superior and inferior portion by the tendinous septum known as the raphe. The presence of the raphe may influence injury patterns and provide a protective effect, which may explain the relatively low incidence of the isolated semitendinous injuries. When isolated semitendinous injuries do occur, they most commonly involve the distal tendon due to its considerable length. MRI accurately demonstrates distal tendon avulsions and the degree of tendon retraction, whereas ultrasound offers high resolution and allows dynamic assessment of the tendon integrity. As one of the authors of this work, I would like to invite you to read the full article to gain a deeper understanding of these critical imaging findings and to better guide your treatment strategies and to place decisions.